So we are pleased to have Nina Sanderson here with us today to share her knowledge of the CMS regulations and her experience working with nursing facilities. Nina has been a licensed social worker in Idaho for the past 24 years, and she now works with Comagine Health as a senior improvement advisor. She's been certified by CMS to conduct both skilled nursing facility and dialysis or ESRD surveys. She has spent 13 years working in a nursing home, 3 years as a long-term care surveyor in Idaho, 3 years as a co-supervisor of the Idaho State Long-Term Care Survey and Certification Program, and 4 years as a federal surveyor. We do ask that people not interrupt during Nina's presentation, but we did want to acknowledge that people may have questions as she moves throughout the presentation. So feel free to put any questions you might have into the chat box, and we'll address them at the end of her presentation today. And now I'm going to turn it over to Nina.
Thanks, Brita, very much for that introduction. And the first thing I'll tell you guys is nobody gets to run screaming from the room because of my background. I work with Comagine Health now, and I'm definitely here to be your ally and strongest cheerleader and supporter, and not beat you up with the regs anymore. If you look at the screen, you'll see that I worked in nursing homes just about as long as I surveyed them. So hopefully that'll give you a little bit of relief. And with that, we'll jump right into some of the regulatory requirements surrounding behavioral health. Next slide, please. All right, we're going to talk about a couple of things that are just kind of related to behavioral health first, that aren't actually part of the behavioral health regulatory grouping. The first one you'll see is that requirement for at F645 for the pre-admission screening and resident review, or PASR. This is that level 1, level 2 pre-admission screening, one of those forms that you have to have filled out typically by the hospital discharge planner or the physician's office prior to a resident coming to the nursing home. And what this requirement says is any resident whose stay is anticipated to be longer than 30 days has to have a level 1 PASR screening, meaning somebody looks at their medical information and makes a determination if their primary diagnosis for placement is a mental health diagnosis per the DSM criteria. Then anyone who is found to have one of those diagnoses as a primary diagnosis is screened for the level 2 PASR, which is that secondary screening that talks about the need for specialized services. The reason that I bring this up is because there's a couple of pitfalls within the PASR screening that you'll want to be aware of. The first is it's often flawed. It's often incorrect when it comes to a mental health diagnosis, simply because a person who's in the hospital is there to have whatever acute condition, be it illness or injury, brought them to the hospital. That's been the focus of their care. And the hospital discharge planner may not have access to mental health diagnoses or any of that information. The other flaw is that sometimes you'll have a resident who's anticipated to be in the facility less than 30 days. They get a level 1 screening, then they end up staying more than 30 days, and that can cause you some problems as well. And the final situation is every state has their own process for the PASR screening. Some are much more involved than others. In the state of Oklahoma, for example, there has to be someone who goes out to the hospital to interact with the potential resident, look at their record, talk with their family, get a really good picture of what's going on. Whereas in other states, the person who fills out the PASR might just get a med list and an H&P, and that's the extent of the knowledge they have about the person. This is one of those times if you discover after the resident comes to your facility that there was a diagnosis that was missed on that PASR screening, get in touch with your PASR screening folks at your state and have them rescreen that individual. There may be some services, first of all, that they require, or second of all, that they would really benefit from. And the way to tap into funding for that might be through the PASSAR process. So just wanting you guys to be aware of that. There typically is not a penalty for reaching back out when you have more thorough information and getting an updated PASSAR. Next screen, please. All right, this is another requirement that's not technically part of the behavioral health requirements. However, there's a lot of overlap between this and some of the behavioral health requirements. This is the requirement at F699 for trauma-informed care. You'll see up here on the top of the screen that I have a little asterisk next to the F699. You'll see that here and again in the presentation, and that what that means is that if this is a deficiency that's found out of compliance at a high enough scope and severity, it can constitute a substandard quality of care. That's not going to happen to any of you guys. What this requirement says is it says that for individuals who have a history of trauma who don't necessarily have a diagnosis of PTSD, the facility has to have an awareness of that trauma and develop a culturally competent care plan for that individual. And in case you're wondering how many of your folks might experience this, SAMHSA estimates that at least 70% of individuals, adults across the board, have had some kind of a traumatic experience that has caused them to change the way they interact with the world. They avoid certain things, they do certain things, they set up their daily routine or their environment in a very specific way to avoid re-traumatization. What this requirement says is that the facility is going to learn about these things and develop a care plan accordingly. The way you do this is through a very thorough social history, which I saw the number of social workers who are on this call today. You guys know more than anybody, this is a very labor-intensive process, and it's not something that you can necessarily learn in one interaction with the resident. You may have to go back over time, develop that relationship of trust, and it may not be until the resident has a behavioral reaction to something that's going on around them that you uncover these kinds of things. This requirement also may kind of indicate that you need to learn about your resident in a way that's outside the cultural norm for your area. For instance, if you have immigrants or refugees, I know there's some of you who talked about serving the Native American population in your introduction. You know that you have some very specific cultural factors that pertain to your residents. Even if it's a resident who might be in your facility from another area of the country. I know I'm a Pacific Northwest girl. I live in a little tiny town, Tico, Washington. I grew up in Montana. If you put me in the southeastern part of the United States, I'm like a fish out of water. So there may be some things that you need to learn about where your resident grew up and incorporate those into their care plan. The best example I can think of, back in the day when I was working in the nursing home, we had a resident who was a refugee from continental Africa. And in the refugee camp where he was staged prior to coming to the United States, the camp guards used dogs to control the residents of the camp to the point where they would maim or kill, and sometimes those dogs were used just for the entertainment of the camp guards. So this individual comes to a facility in Idaho where, we love our dogs, and dog therapy day is a great day in the nursing home, right? But not for this individual. We had to make sure that we had him out of proximity of the dog because that was incredibly traumatic for him. Next slide, please. All right, now we get into the behavioral health regulatory requirements. This starts at F740 for behavioral health services. This is a very high level requirement that says you have to provide the necessary care and services to individuals who have a mental health diagnosis, substance abuse disorder, those kinds of diagnoses per the criteria in the DSM or SAMHSA. to help them attain or maintain their highest practicable physical, psychosocial, and functional well-being. And that's a phrase that you see in a lot of regulatory requirements. When it comes to the behavioral health requirements, it becomes a little bit more dicey to define and measure that kind of thing. But before we get to the end of the presentation, I'll give you the secret sauce of how you can do that. It's a very broad requirement. It talks about everything from qualified staff to assessment to individualized care plans and PASSAR services. The goal of this requirement is to minimize drug use and related adverse reactions to drugs, reduce behavioral escalation, and reduce dependence on the emergency room for those behavioral escalations. Next slide, please. All right, the next requirement is at F741, which talks about sufficient and competent behavioral health staff. What this regulation says, in a nutshell, is that you'll have enough staff with sufficient training to meet the needs of the competency elements that you see on the screen. This requirement pertains to all your staff, not just nursing staff. So it would be anyone who's interacting with your residents, housekeepers, laundry, maintenance folks. And this can be what they have to have is they have to have the skill set so they have a basic understanding of any of the mental health diagnoses that your resident may have, and then some of those specific things they need to do or not do when they're interacting with that resident. This can be something that's broad within your facility. Any of you who are working in veterans homes or working with veterans know that there's a high correlation between being a veteran and having PTSD. So that might be something that you have to do on a broad scale in your facility. But if you have even one resident with a mental health diagnosis, you need to make sure that your staff have the skill set they need to interact with and care for that resident. When I think of this, I think of a gal we took care of years ago. I'll call her I'll call her Alice. She was so cute. She was an incredibly resilient woman. She had a diagnosis of bipolar disorder back when it was very unusual for folks to get any kind of an official diagnosis, and there was an incredible stigma attached to it. And Alice stepped into, kind of backed into her diagnosis like most of our folks do, where she had a substance use disorder. And then through the diagnosis of that, it was found that she had bipolar disorder as well. Several times throughout her adulthood, Alice was hospitalized to get a bit of stability with her bipolar disorder. When she came to the nursing home, it was because she had had a stroke. And at first, Alice just terrified the staff. She carried around a little notebook with her and a pen, and she was always threatening to write down the staff names and report them. And she was always, kind of doodling in that book, even though she couldn't really write anymore because of the stroke. But the staff were terrified that they were going to be reported for abuse and lose their jobs. We were able to get enough historical information about Alice's hospitalizations that we discovered one of the tools that worked for Alice was that she would journal whenever she was hospitalized. And that was something that she was relying on to help her cope with her nursing home placement. When we were able to share that with the staff, they became much less fearful of taking care of Alice. And, she turned out to be just this delightful woman. She had a wicked sense of humor and was very beloved by staff once they had the right tools to provide her care. Next slide, please. All right, this is F742, which is treatment and services for mental health disorders, which is very closely related with trauma-informed care. This is almost the same verbiage verbatim as you will find in F699 for trauma-informed care, only this is for individuals who have an official diagnosis of a mental disorder, psychosocial adjustment disorder, or PTSD. And there are some groups of individuals who have a higher predominance of these psychosocial adjustment disorders and PTSD. Veterans, as we've already discussed, it could be survivors of sexual assault, survivors of terrorist attacks, survivors of natural disasters, or survivors of a genocide event such as the Holocaust. This involves not only that thorough social history that we talked about getting for the requirement at F699, but it also involves a physical evaluation of the resident to look for scars or tattoos that might be indicators of trauma or torture or abuse. And it could involve interviews with residents or family members or friends if the resident is no longer able to speak for themselves. If you have a resident who is cognitively intact and they're choosing not to share this stuff, they do still have the right to privacy. But if their communication or cognitive skills are impaired, you may need to get this information from family members. The best example I can think of this, and I see some of you on the call today are from California. Back in 2018, the Paradise Fire in California was a pretty traumatic event for everyone in those communities. But for the nursing home residents, they were first evacuated from their nursing home because the nursing home was in the path of the fire. They were evacuated to the hospital. The nursing home burnt down. Then they had to be evacuated from the hospital because the hospital was also in the path of the fire. And they were, emergency services were already deployed. There were no ambulances to transport folks. There were no emergency medical personnel to transport them. They were essentially putting people into the back seat of a broken down Honda that was driven by a CNA who was also terrified. And evacuation routes were largely becoming impassable. So, these folks kind of scattered to the wind under very traumatic circumstances. A year later, they were still displaced. The nursing home and hospital in their hometown were both gone. Their families couldn't visit. They were having to give testimony in some of the legal proceedings surrounding that event. And then there were fires that happened in the area where they had been evacuated to. So these were things that, there was a diagnosis of PTSD, and the staff had to be very sensitive to the trauma that this was causing their residents. Next slide, please. All right, this is a common thing that you'll see in the reg, where in any regulatory grouping, it'll have that, something bad that hasn't happened doesn't happen unless it's unavoidable. And in this case, it's that no pattern of behavioral health difficulties unless unavoidable. This says for your folks who have a mental health diagnosis, they need to get treatment and services to prevent that from deteriorating, unless there's something going on that it just can't be helped. And for your folks who don't have a diagnosis, they don't develop a mental health condition unless that's unavoidable as well. What this is going to require is that you have some kind of system for monitoring how folks are doing in terms of their mental illness, and that you know what to watch for as an indicator that they're decompensating with their management of that condition. Get them services, get them medications. This again involves that you sit down with this resident, sit down with their family, find out, okay, diagnosis of bipolar disorder. How do we know that it's escalating for this individual, and what do you typically do to get treatment, and how can we go about getting that in the nursing home? Next slide, please. All right, I love that we get to see lots of social workers on these calls. This is medically related social services, and this is a requirement that is placed under the behavioral health regulatory grouping. But if you look at this list, there's a lot of things on there that aren't just behavioral health related. This is a big job. My cautionary tale to those of you on the call who are social workers, please, please, please advocate to your administrator for the amount of time you need in your department to do these things. For those of you who are administrators, this is the time of year when you're putting pencil to paper coming up with your budget for the coming fiscal year. please, please, please look at the list of things on this page and recognize the amount of time it takes to do them well and correctly. The other thing I would encourage both social services staff and administrators to know is that there's not necessarily a requirement that you have to have a licensed social worker. And in some states, you don't even have to have anyone with any kind of specialized training or skill set to do these jobs. Um, Make sure that when you're budgeting for time and folks in your department, that you're budgeting plenty of time for consultation and training to set your residents up for success when it comes to these really important things. And I am a little bit biased. My background is as a nursing home social worker, but these are important things, and it's important that you do them. Next slide, please. All right, this is the only time, this is my last slide in the presentation, and this is the only time you're going to see me step outside of the regulatory requirements. But this is a document that's affiliated with the regs. It's not necessarily one of the regs, but it certainly is a tool that surveyors use. And Adrian, if you would go ahead and drop that link into chat, that would be great. This is the Psychosocial Severity Outcome Guide. It is only 7 pages long, and it is pure gold when it comes to your behavioral health programs. When you look at those terms on the screen, the Psychosocial Severity Outcome Guide provides definitions of those terms and talks about how you can quantify them. The surveyors are going to use this to beat you up. They're going to find something that's wrong, and they're going to use this Psychosocial Severity Outcome Guide to show that it's actually worse than you thought. But you can use this proactively to write your care plans in ways that you can create measurable goals, to formulate conversations with residents so that when they're talking about getting angry and you're listening to them talk about that, you can define that and quantify it and really set your residents up to be successful by writing really good care plans. It differs all of these things from a normal grief reaction, which I think sometimes we lose sight of that in the nursing home. We don't want anyone to ever be angry or tearful or fearful. And I don't know that that's realistic. Folks are folks, right? They're going to have that same range of emotions that any of us do anywhere that we are. But this will say, okay, normal grief reaction might be, XYZ. But if we see these other things, it's an indicator that something more severe is going on. This this guide relies on the reasonable person concept, which is something that you find in a lot of areas of law. But essentially what it's saying is, if this event happened to any other person, how would a reasonable person respond? How would a reasonable person respond to being placed in the nursing home, to not having staff take care of them who are knowledgeable about their condition, to losing their privacy, to sharing a room with somebody they don't know, any of those kinds of things. So I highly encourage you to get into that link that Adrian dropped into chat and familiarize yourself with that guide. All right, that's all the talking I can do about regs in one day. I know they're kind of boring, and I appreciate you sticking with it. What kind of questions do you guys have for me?